before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. You hear an obstetrician talking to a patient called Melissa Gordon. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So this first meeting, Mrs. Gordon, is mainly a chance for you and I to get to know each other. I'll ask about your medical history, and this is also an opportunity for you to ask me any questions that you've got at this point.
Sure.
So some background. What kind of work do you do?
I have a job at an engineering company. I'm a computer programmer. I currently do 4 days a week, but I hope to reduce that to 3 after my maternity leave.
Ah, excellent. So tell me about your medical health. Do you have any conditions I should know about?
Well, I have asthma attacks, but they don't happen often. I lost about 10 kilos, and that certainly helped. I have an inhaler, but I hardly ever use it. Oh, I should also let you know that I come out in terrible hives if I take penicillin, but not other things. I'm fine if I eat nuts, for example. I have a fairly healthy lifestyle. I'm a vegetarian and I've never smoked.
Good.
I'm afraid I don't go to the gym or anything, but I walk to work and generally keep active.
Oh, that's good. So this is your first pregnancy?
No, I have a daughter called Ella. She's 3 now.
Ah, and did everything go smoothly that time?
There were no major problems during the pregnancy itself, but it took me quite a time to fall pregnant the first time. After having various tests, I was given some fertility drugs. Oh, what were they called? It's on the tip of my tongue. Never mind, it'll come back to me. This time, though, I didn't need any help.
Oh, it's no problem. What about labour last time round?
Oh, that was a nightmare. Though everything, thank goodness, worked out in the end. It was a breech birth. It looked as if I might have to have a caesarean, and I really didn't want that. I was pleased I managed without an epidural, too. They had to use forceps to get Ella out, but I didn't need any stitches, so that was okay. Unfortunately, though, I had some difficulties after the birth too. I was desperate to start breastfeeding, but that didn't work out. At least not until I was given some guidance by the midwife.
OK. So can I ask you about the baby's father?
Sure. That's my husband, Paul. There's something in his family history that I should tell you about, I think. His grandfather and father both had epilepsy, though he hasn't developed it himself. I'm not sure if that means his children have a greater chance of having it or not. Oh, also, he has a child from his first marriage, and she has Down syndrome, so he gets a bit anxious when I'm pregnant.
Oh, well, that's understandable, of course. We can discuss various testing options if you like. You might want to consider amniocentesis, for example.
But that carries a risk of miscarriage, doesn't it? I don't want to go for that. I've heard about another test called CVS. Is that something to consider?
Well, it's certainly an option. However, that procedure, in fact, also carries a small increase in the risk of miscarriage. And you'd need to come to a decision fairly soon, because it's normally carried out between weeks 10 and 12 of the pregnancy.
Well, I can tell you straight away that if there's more risk, then I wouldn't consider it. I know my husband will feel the same.
Well, that's fair enough. So, is there anything else you'd like to ask me about today?
Nothing urgent. But it'd be good to know more about how to get siblings ready for a new addition to the family. I want to make sure Ella doesn't feel threatened or replaced or anything.
Well, there's a leaflet that many parents find helpful. Here we are. Have a look through that.
Oh, thanks. That's great. I'm sure I'll have lots more questions at our next meeting.
Extract 2. Questions 13 to 24. You hear a GP talking to a new patient called Mike Royce. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello? Coming in. You must be Mr. Royce. I understand that you've just signed up with the practice.
Yeah, that's right, Mike Royce. I've joined this practice because my previous GP retired and he suggested I come here.
Right, and I understand you've got an ongoing medical condition you're worried about? Perhaps you'd like to start by telling me about that. How did it start?
Well, I suppose it started out as a really strong pain in my left knee. I think it's called the medial meniscus. Mm-hmm. Is that right?
Mm-hmm.
It came on whenever I tried to bend the knee more than normal. Then I tripped while climbing some stairs at work, and that seemed to make things worse. I started to get these very tender bumps all over the back of the knee.
Right.
They were very painful, even just lightly touching them. The doctor called them trigger points.
Yeah, that's right. They're called that because pain frequently radiates out from them when touched. And how did that affect you day to day?
Well, I went back to work after a week or so, but I was still having knee problems. I couldn't really squat properly or climb ladders. That's important in my job. I'm a painter, and I'm always having to get into awkward positions. Anyway, I kept going back to my old GP explaining that I still had severe pain whenever I tried to bend my knee. He gave me all these exercises to do, and I tried doing them. I really did. I made sure I did gentle stretches before I did anything more energetic, everything really. I tried resting like he told me. I used ice packs when it got sore, but nothing really worked.
Right, I see.
But then the doctor decided I might be suffering from tendinitis, so he sent me for some rehab work in the hospital. That actually did seem to work, at least at first.
But I'm guessing not for long.
Right, the problem came back. I kept telling the doctor that my knee still wasn't healed, but it was actually my physiotherapist in the hospital rather than my old GP who noticed that something was wrong with my muscles. He wouldn't say what it was, but I knew something was up. He was doing myofascial release on my hamstrings, and I was in agony.
Right, so did you go back to your GP?
I did, but he didn't know what I should do about it, so I left feeling completely fed up. That's one of the reasons I decided to come here.
Okay.
I just feel like nobody's taking this seriously. I think it's affected my life in lots of other ways too. The worry's given me insomnia, for one thing. I don't think I have actual depression, but I certainly suffer from constant anxiety about when it's going to flare up.
Is there anything that you're particularly worried you might have?
Well, I've researched this pain I'm getting. To be honest, I'm convinced I've got fibromyalgia, not just some simple muscle problem, because I fit most of the symptoms, and I've had pain absolutely everywhere. Look, I've even kept a pain diary so that I could track what I did that set it off. The weather, if I was working or not, where it was affecting me, what it felt like.
Oh, good.
I figured out from this that it's usually in the same places that I mentioned earlier, plus some newish places too. My shoulders and elbows. And I know that my knee's actually one of the more tender points for it. What do you think?
Look, I must say from what you've told me so far that I'm concerned enough to look into that possibility. So as a next step, we need to get you seen by a rheumatologist. This is a notoriously difficult condition to diagnose, as I'm sure you're aware, because so many of the symptoms overlap with other conditions too.
I won't be happy to be proved right, but I'll certainly be glad to get some answers at long last.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a dietitian talking to a patient. Now read the question.
So what seems to be the problem?
I feel such a failure. I'm sure people think that if I just tried harder, I could lose weight. Maybe I need more willpower.
Well, firstly, well done for seeking medical help. Actually, being overweight or obese is a medical problem, because being overweight changes how your body works.
Oh, thanks, but I do feel that it's my fault for being this way.
Well, I hear what you say, but please understand that these days we consider that obesity is a disease, like high blood pressure or asthma. You see, the body's signals to the brain stop working correctly when you're overweight, and with time you feel less full, even if you eat the same amount. And when you cut calories, your body tries to use less energy to keep your weight the same.
Question 26. You hear members of a hospital committee discussing problems in the X-ray department. Now read the question.
So next on the agenda is the problems in the X-ray department. Nick, would you like to fill us in here?
Well, as you all know, this is a very busy department, so we have 4 X-ray machines in all, including one in the fracture and orthopedic clinic area. But recently, one of the other X-ray machines developed a fault, and so we had to apply for authorization for the purchase of a new tube for it. There's been some kind of hold-up with the paperwork, and while we've been waiting, patients are being brought into the fracture and orthopedic area for X-rays there instead. And of course, that's causing further congestion.
Question 27. You hear a senior nurse giving feedback to a trainee after a training exercise. Now read the question.
OK, that went quite well, didn't it? But it took you a while to work out where the CPR board was kept.
Yeah.
So what does that tell you about this scenario?
We need to check where things are before doing anything else.
Exactly. And of course, it takes a second or two to put the head of the bed down, because you've got to have that part of the bed flat before you slip the board in. I wish there was a quicker way.
So do I put the CPR board under, or would I normally hand it over to somebody else?
It makes no difference as long as it's done.
Question 28. You hear a trainee nurse asking his senior colleague about the use of anti-embolism socks for a patient. Now read the question.
I noticed that Mrs. Jones isn't wearing the usual anti-embolism socks, but I didn't want to ask her why not because she was asleep. Is it because her legs are swollen?
Well, sometimes we don't recommend the socks if there's severe swelling with edema, but that's not the case here. Mrs. Jones was actually given them initially on admission last night, but she told us this morning that her lower legs were feeling numb. She described it as having no feeling. Until we've checked out the reason for that, for example, it could be an underlying condition which could damage her arterial circulation. We're reducing the risk of thrombosis by pharmacological means.
Oh, I see.
Question 29. You hear a vet talking about her involvement in the management of the practice where she works. Now read the question.
At first, when I took over the financial running of the practice, I felt rather thrown in at the deep end. I really needed to know my stuff and be super organised, especially with the number of new drugs and treatments available now, all of which have to be very carefully costed. It keeps me super busy, but monitoring stocks and so on helps give me confidence and allows me to see how everything fits into the overall picture of working as a vet. My manager's more than happy to leave me to run this side of things. He's in overall charge, of course, but I can always go to him if there's a problem. I keep him closely informed of what's happening. He's always pleased if I manage to make savings anywhere.
Question 30. You hear a physiotherapist giving a presentation about a study she's been involved in. Now read the question.
I'm a physiotherapist, and I'm presenting our poster about constraint-induced movement therapy for children suffering from partial paralysis following brain surgery. We did a case series of 4 children who'd all undergone hemispherectomies. They were admitted to inpatient therapy within 2 weeks post-op and began therapy 2 to 3 weeks post-op. The therapy continued after they were discharged. Our findings were that 3 of the kids regained excellent function and mobility with ambulation and upper extremity function. 1 didn't do so well, unfortunately, but he gave up the therapy early on. This type of movement therapy has been used a lot in adult populations following stroke. The findings here promote moving forward with further research on the pediatric or adolescent population following either hemispherectomy or other surgeries, to help us decide how appropriate this therapy would be for them.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. Questions 31 to 42. Choose the answer A, B, or C, which fits best according to what you hear. Look at Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Now, answer question 1. The word migraine is derived from the Greek word meaning pain in half the head, as migraine often produces a unilateral or one-sided headache. It is a common and distressing disorder, and although they are not likely to take life, migraines can destroy the quality of life. Studies have shown the incidence of migraine to be in the range of 9 to 10%, and it affects 17% of the female population and 6% of the male population. So, about 2 million Australians can expect to suffer from migraine, and that translates to 1.5 million women and about 500,000 men. It is thought that more women suffer migraine than men due to hormonal factors. There are several types of migraine, the two main types being classical migraine and common migraine. Classical migraines are preceded by an aura, the duration of which varies between 15 minutes up to almost an hour. The headache usually lasts 6 to 8 hours, although they can last up to 72 hours. Common migraines are not preceded by an aura, and the headache lasts between 4 and 72 hours and can be pulsating and unilateral. An upset stomach and vomiting are common symptoms. Migraines can be divided into a number of distinct phases. The first phase includes the early warning symptoms. A significant number of migraine sufferers experience warning symptoms for up to 24 hours before the attacks start, but may not recognize these signs unless they know what to look for. The common symptoms include changes in mood, and these moods can vary from elation, such as feeling on top of the world and full of energy, to opposite moods, such as feeling depressed and irritable. There are several abdominal symptoms common to migraine, including nausea, changes in appetite, such as intense hunger or sugar craving, constipation, and diarrhea. Neurological changes may also occur prior to the migraine, including drowsiness, incessant yawning, symptoms of dysphagia, such as difficulty in finding the right words, a reaction to excessive brightness or sound, and difficulty in eye focus. There may also be changes in behavior, such as hyperactivity, clumsiness, or lethargy. And many sufferers report muscular symptoms, such as general aches and pains. The second phase is the aura. The aura accompanies migraine attacks in about 20 to 30% of migraine sufferers. The most common aura symptoms are visual disturbances such as bright, zigzag lines and flashing lights. As well as that, there may be difficulty in focusing or blind spots. The aura commonly affects only one eye, but it can disturb the visual field of both eyes. It usually lasts between 5 and 60 minutes, then the vision normally returns to normal. Less commonly, aura affects sensation or speech. The third phase is the headache. The headache phase can last for up to 3 days. It is often throbbing and on one side of the head, but it can affect both, and it is made worse by any kind of movement. The most common accompanying symptoms in this phase are sensitivity to light, sound, and smell. Eating can help reduce symptoms, especially starchy foods such as breads and pastas. The symptoms can be more distressing than the headache itself. The final recovery stage may last for about 24 hours, and feelings range from complete lethargy to feelings of high energy and even euphoria. Sleep often is beneficial for adults, while effective medication can improve attacks for chronic sufferers. Children seem to feel much better after vomiting, and for a few, nothing works except the headache burning itself out. The dietary triggers include alcohol, especially red wine, certain types of food, notably aged cheese or chocolate, withdrawal from caffeine or caffeinated drinks such as coffee and tea, the food additive monosodium glutamate, dehydration, and inadequate meals. Environmental triggers include bright sunlight, flickering lights, strong smells, for example, perfume, gasoline, chemicals, smoke-filled rooms, and certain food odours. Another environmental trigger is high altitudes or flying. Weather changes can be a trigger factor, as can loud noises or overuse or incorrect use of computers. Other trigger factors include the hormonal triggers. Hormonal fluctuations are implicated as a significant trigger for women, as 3 times as many women suffer from migraine headaches as men. This difference being most apparent during the reproductive years. The hormonal triggers may be menstruation, and a UK study found that 50% of women are more likely to have migraine around menstruation, ovulation, use of oral contraceptives, pregnancy, and it may be worse for the first few months, but in 2/3 of women it improves in the latter part. The physical and emotional factors which can trigger migraine include a lack of sleep or oversleeping, and even as little as half an hour difference in routine, such as sleeping in on the weekends, can make that difference. Illness, such as a viral infection or a cold, stiff and painful muscles, especially in the scalp, jaw, neck, shoulders, and upper back, sudden or vigorous exercise, emotional triggers such as arguments or excitement, and relaxation after stress, which is known as the weekend headache. There are a variety of treatments available for migraine sufferers, and non-medication treatments such as ice can, in some cases, reduce the impact of a migraine episode. This is because, during a migraine, the blood vessels in the head tend to dilate, which means they open more widely. They may become swollen with blood, and this in turn leads to pressure on the nerves surrounding them. The nerves begin to send pain signals before the onset of migraine. Wrapping the head with an ice pack can bring migraine relief through the cooling of the blood vessels. As the blood vessels cool, they become constricted and return to normal size. This can lessen blood flow to the head and, as a result, reduce pressure on the nerves, thereby providing relief from pain. Another non-medication treatment is biofeedback. The biofeedback technique trains people to improve their health by controlling certain bodily processes that normally happen involuntarily, such as heart rate, blood pressure, and muscle tension. Relaxation techniques may also be helpful at stopping an attack once it has started. The techniques include deep breathing, massage, and stretching. Individuals with occasional mild migraine headaches that do not interfere with daily activities usually medicate themselves with over-the-counter, non-prescription pain relievers such as paracetamol, aspirin, or NSAIDs like ibuprofen. For people who suffer migraines very frequently, prophylactic medication that is taken on a daily basis may be a good option. As a general rule, patients who experience migraines twice or more per month or have migraines which interfere with their quality of life may benefit from this type of medication.
Extract 2. questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
I'm here with Dr. Jeffrey McLean, who's an expert in neuromuscular disease. Tell us a little bit about your background. How did you become a neuromuscular disease expert?
Well, I started out with my general neurology training, which I did at Wilford Hall Medical Center. And from there, I did a fellowship in neuromuscular medicine before returning to where I am now.
And what's your typical day like? What kinds of patients do you see?
I see a fairly broad mix of patients, but when I'm doing specifically neuromuscular medicine, I do a lot of procedures, electromyography, which is a procedure that we use to help diagnose neuromuscular diseases. The type of patients we see range from patients with neuropathies to patients with muscle diseases that we call myopathies, to patients with disorders of the connection between the nerves and the muscles, neuromuscular junction disorders such as myasthenia gravis, to problems with the motor neurons such as ALS or amyotrophic lateral sclerosis.
So a variety of very common diseases and some that are more rare and very have very serious prognoses.
Exactly, that's right.
And what is the most exciting new development in your field? Which of those conditions have something new to offer patients who are listening?
I think perhaps the most exciting field where we've seen a lot of attention recently has been ALS, especially with the Ice Bucket Challenge recently that garnered so much public attention, so much public excitement. That excitement has transferred into more attention, more funding for more research, things that are looking at improving our understanding of the genetics that play into ALS, where there's a lot of work being done trying to find biomarkers, so things that can be tested easily to more readily diagnose ALS and understand how it progresses in a particular patient. All these things ultimately help us find and research possible treatments that in the end are hopefully will lead us to things that will really benefit patients.
And up until now, there really has not been a great deal to offer an ALS patient. What do you do today?
Right now, what we're focused on is improving the quality of life while people are dealing with this disease. And that's an important thing for both patients and physicians to understand, that while we don't have a cure, there are many things that can be done to significantly improve the quality of life for our patients. So things like help with communication, because many of the patients lose the ability to control their voice and control their speaking. So we can do things to help them communicate as that occurs. Things like assistance with nutrition, because they have difficulty swallowing and eating. So helping them with that. One of the big and often under-recognized problems with ALS are mood problems that go along with it. Obviously, it's a devastating diagnosis. And the social support is very important, that we offer that to our patients to make sure that they're again, their quality of life is as high as possible while dealing with this.
And on the other end of the spectrum, we have neuropathies for which we can offer a whole variety of treatments. Is there anything new or exciting for the patient with diabetes or someone else with neuropathy to consider?
Well, again, there's a lot of new research going on. There's a lot of exciting work in terms of trying to find ways to treat the often painful diabetic neuropathies. There are already some drugs currently available that many patients will be familiar with, and as time goes forward, we hope to increase the number of drugs that are available to make them more effective with fewer side effects. So hopefully that will be very soon on the horizon.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.